Hello and good evening, all dear friends, colleagues from all around the world. We are so proud to be here with you with the fourth day of the 33rd International Congress on Pediatrics. Such a great honor for us for having you here. I'm Dr. Mahia Kahramanlu, pediatric resident at Tehran University of Medical Sciences, Children's Medical Centers Hospital. Today we are going to have two particular sessions. First of all, we will going to start with pediatric gastroenterology updates, and then we will go on difficult anemia in children. So many thanks to dear Dr. Pejman Rouhani for arranging the first session for us, and then so many thanks to dear Professor Amita Trohan for arranging the amazing difficult anemia session. I'm so excited for today. Sorry. Now we are live on our YouTube channel as Pediatric Webinars TUMS. Dear participants, please log in with your full name in English and do not forget to register on our web application. You will receive your certificate of attendance within 7 days in English. So please join with your full name in English because the list of Zoom audiences will be matched with the list of registered applications for attendance certificate. And also, dear Iranian participants, you will able to receive your CME credit for these sessions. So please follow www.ircme.ir and do not forget to take the exam at the end of the sessions to receive your CME credit. We will go to start our first session, gastroenterology. In pediatrics, dear Mariam, let's go on. Hello again, welcome to our dear friends and colleagues from all around the world. We will have four amazing and particular distinguished lecturers today. Professor Carlos Lipschitz, Dr. Mohamad Miqdady, Dr. Pejman Rouhani, and Dr. Christos Tzivinikos. First of all, we are going to start with Dr. Carlos Lipschitz. Unfortunately, we lost him in a few minutes ago due to internet problems. So we will use his backup video and hope he will join us soon. So we will start with gastroesophageal reflux in children and its updates. Let's get started. Professor Carlos Lipschitz is an American Board of Pediatrics certified pediatric gastroenterologist and former associate professor of pediatrics at Baylor College of Medicine, Houston, Texas. He currently is an associate physician at the Italian hospital Buenos Aires, Argentina. He has served in the Council of the North American Society for Pediatrics, Gastroenterology, Hepatology, and Nutrition, as well as in the editorial board of the Journal of Pediatric Gastroenterology and Nutrition, Currently in the International Editorial Board of the Journal of Pediatric Gastroenterology, Hepatology, and Nutrition. He is a member of the European and Latin American Societies for Pediatric Gastroenterology and Nutrition, and former member of the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. He is the author of 95 peer-reviewed publications and 2 books. Now we'll start by his lecture.
Hello, good afternoon. I'm very happy to be invited to give this talk at the meeting organized by the Tehran University Medical School. My name is Carlos Lifschitz. I'm an associate physician, pediatric gastroenterology service at the Italian Hospital, Buenos Aires, Argentina, and former associate professor at Baylor College of Medicine in Houston, Texas. And the topic is gastroesophageal reflux. First, let me present to you what are the mechanisms by which reflux does not occur. Here in this slide, we see the esophagus, the crural diaphragm with the esophagus going through it, and here forming the angle between the esophagus and the fundus of the stomach called the angle of His. And therefore, we also have the different pressures, the thoracic pressure and the intra-abdominal pressure. The esophageal factors that prevent reflux are the lower esophageal sphincter tone, esophageal clearance, gravity, and the buffering by saliva. While non-esophageal factors that prevent reflux are the diaphragmatic pressure, the angle of His, the abdominal thoracic pressure differences, the phrenoesophageal ligament, and the gastric emptying. Gastroesophageal reflux is defined by the effortless involuntary passage of stomach contents into the esophagus. When the regurgitate is high enough and it can be visualized, then it's called regurgitation. It may or may not be symptomatic depending on the acidity of the reflux, and it accounts for approximately 20% of the pediatric gastroenterology referrals. On the other hand, vomiting is a central nervous system reflex involving both autonomic and skeletal muscles in which gastric contents are forcefully expelled through the mouth because of coordinated movements of the small bowel, stomach, esophagus, and diaphragm. So reflux is involuntary while vomiting is voluntary. Gastroesophageal reflux disease is when regurgitation of gastric contents causes complications or contribute to tissue damage or inflammation, causing esophagitis, obstructive apnea, reactive airway disease, pulmonary aspiration, feeding and swallowing difficulties, or failure to thrive. In this sketch, we can see a probe. This is a catheter, which is called a pH probe, and we will use it for determining acidity, regurgitation from the stomach up into the esophagus. It has a higher detector and a lower detector, so we can see how high the reflux goes. And I present this here because a lot of the things that I will mention afterwards relate to determinations by pH probe. There is another method of measuring reflux, which is called impedance, but we will not discuss that today. So this can be done in adults and of course in infants as well. By pH probe, it has been determined that the most frequent mechanism underlying children of any age in a transient is a transient relaxation of the lower esophageal sphincter. So that's the most common mechanism by which GER occurs. This transient relaxation of the LES is an abrupt decrease of an LES pressure to the level of intragastric pressure that is not related to swallowing. It is accompanied by an inhibition of the esophageal body and crural diaphragm, and is of relatively longer duration than those relaxations that occur when we swallow. In this pH probe tracing, we can see here how the LES pressure decreases and how that is followed by regurgitation, showed by the decrease in the esophageal pH. Well, let's first talk about functional gastrointestinal disorders, and that is regurgitation in the neonate and toddler. The diagnostic criteria for infant regurgitation include both of the following in otherwise healthy infants who are between 3 weeks of age and 12 months of age. The regurgitation has to occur 2 or more times per day for 3 or more weeks, and there is no evidence of retching, hematemesis, aspiration, apnea, failure to thrive, feeding or swallowing difficulties, or abnormal posturing. Normal gastroesophageal reflux, as determined in normal infants by pH probe, shows that in less than 2 hours after a baby eats, there can be up to 5 episodes per hour of reflux. The reflux is greater in the upright position in normals, with a sudden pH drop and slow stepwise return to normal pH. Rarely reflux while asleep, and there is a difference between prone and supine, where in supine the reflux is 7 times greater than in the prone position. So as I mentioned before, the functional GER begins before 3 months of age, does not occur during sleep, although babies might regurgitate while asleep. It does not impair with growth. There are no symptoms except effortless reflux, and that's why these babies are called happy spitters, and it starts improving after 6 months of age. When we looked at the prevalence of regurgitation in infancy, we can see that in yellow is when they vomit, when they regurgitate only between 1 and 4 times a day, and in green more than 4 times per day. We can see that the majority of episodes occurs between 4 and 6 months of age, where about 65% of infants will have at least 1 episode and less than 4 episodes of regurgitation per day, while much less so of more than 4 times a day. And this starts decreasing with age. And another study done by Dr. Ivan van der Plas, and I thank him for this slide, we can see that the curve of prevalence of reflux increases substantially between 0 and 4 months and start decreasing thereafter, where then the majority of babies will have, 70% of the babies will have reflux under 6 months of age, and only a very few after 8 months of life. And the amount of baby, or the number of babies who will have disease from this, is less than 3%. Well, what happens with these babies that have reflux in the first few months of life? So this is a study that's now 20 years old by Martin and al. From Australia, and the aims were to determine the natural history of infants spitting up, they call it spilling, during the first 2 years of life, and the relationship between infants spitting up and reflux symptoms at 9 years of age. So this was a cohort that was followed with daily symptom diaries from birth to 3 years of life, and the records were reviewed at 9 years of age. And of almost 700 babies and children that were interviewed at 9 years, which was 83% of the original sample, it was seen that those infants with spilling on more than 90 days of life during the first 2 years of life, more of 90 days per year in the first 2 years of life, had more likely symptoms at 9 years of age. The relative risk of 2.3 of 1 or more reflux symptoms at 9 years of age were increased in those infants, 4.6 for heartburn, 2.7% for vomiting, and 4.7 for acid regurgitation. Factors that were seen that worsened the chances of these babies to continue having symptoms were pre-pregnancy smoking and smoking in the same room as a child at 9 and 18 months of age. Again, so this represents what happens, the prevalence of the proportion of children with spit up, and how it decreases dramatically from 6 months of age onwards. It has also been shown that there is a lack of correlation between crying, irritability, and gastroesophageal reflux, and it has been concluded that gastroesophageal reflux is not a common cause of unexplained crying, irritability, or distress behavior in otherwise healthy infants. How do we make the diagnosis of gastroesophageal reflux? Of course, by history, physical examination. We may be indicated to order an upper gastrointestinal series X-ray, contrasted X-rays, in the case that the child has forceful vomiting, bilious vomiting, or anything that makes us think that there might be an anatomical problem like malrotation. It is helpful then to rule out pyloric outlet obstruction, esophageal stenosis, pyloric stenosis, duodenal web, which is more common in infants with Down syndrome, and malrotation. The milk scan is not a useful test for diagnosis of gastroesophageal reflux, and upper endoscopy might be indicated when symptoms don't improve despite of therapy. As I mentioned before, the contrast radiography, although is widely available, the cost is minimal. It does only define anatomy and does not establish a diagnosis of gastroesophageal reflux. Here, it is difficult to know if the column of barium is going down or going up. Here, we can diagnose a hiatal hernia, which might be an indication for more aggressive therapy, medical therapy. And here we see malrotation, which definitely has surgical indications, and pyloric stenosis is no longer diagnosed by X-ray. As I mentioned before, in the less than 2 hours postprandial period, there is early gastroesophageal reflux, which is physiologic and is very common. But after 2 hours is the late gastroesophageal reflux associated with delayed gastric emptying, which might be a problem and may be related to some motility problem or to cow's milk allergy or eosinophilic duodenitis. What other factors can give you a false abnormal pH probe? Well, feedings with acid pH, reflux promoting foods, liquid more than solids, acid pH medications in general, chest physical therapy, tracheal suctioners in children with tracheostomies, and coughing. But you can see that the normal number of episodes in infants and children is quite high. Up to 73 episodes of reflux are common in infants, 25 in children, and 45 in adults. Even longer episodes of reflux, more than 5 minutes, are not uncommon in infants and children. So again, the pH probe has shown that pathologic acid reflux does not necessarily correlate consistently with symptom severity or demonstrable complications. It is useful for evaluating efficacy of anti-secretory therapy, may be useful to correlate symptoms, for example, cough, chest pain with acid reflux episodes, and to select those infants and children with wheezing or respiratory symptoms in whom GE reflux might be an aggravating factor. The sensitivity, specificity, and clinical utility of pH monitoring for diagnosis and management of possible extraesophageal complications is not well established. What about the acute life-threatening event? Well, that is also a very controversial issue. It depends how long the event lasted. Did the infant stop breathing? Did they make respiratory efforts? Was the infant's heart beating? Was stimulation required to resolve the episode? Was there a color change noted? Did the infant choke, gag, or vomit with the event? Were there any abnormal movements, stiff or limp extremities associated with the event? And was there any evidence of recent fever of illnesses that might guide us into a more complicated situation? If the pH probe or impedance studies suggest a temporal association between reflux and the life-threatening episode, their management include acid suppression and thickening of feeds. In very severe cases where the recurrent life-threatening episode occurs, the surgery may be considered. But it has been shown, and we have seen this in our group, this is a study published by our group, no particular sequences of events is observed in infants with life-threatening events, meaning that sometimes the pH drops before the episode, sometimes after, and sometimes during. As it can be seen here, there is apnea, and there is a simultaneous recording of drop in pH and apnea. So it is not very helpful to diagnose there. Here we have, on the other hand, apnea preceding the episode of gastroesophageal reflux. No breathing. And here we have apnea following the episode of gastroesophageal reflux. So it's very difficult to determine if reflux is the cause or consequence, or even if it's related to the acute life-threatening episode. Xanthines, which are very commonly used in premature infants, might increase the risk for gastroesophageal reflux. So what is the algorithm for management? If the child has more than 4 regurgitations per day, more than 2 weeks, and the age of onset is between 3 weeks and 6 months, if that's the no, consider other conditions and refer to a specialist. But if yes, then we can check the frequency of feeding, decrease the volume, make sure that the baby's positioned correctly. If the baby is formula fed, we need to use a bottle that does not permit the entrance of so much air in contact with the baby's mouth. Is there also hematemesis, arching, Sandifer syndrome, neurological abnormalities, neurodevelopmental delay? Well, if there is yes, that's a problem and the baby needs to be referred. But if not, we need to just reassure the parents, perhaps if the baby is in formula, use an anti-reflux formula, positional treatment. If the symptoms continue and there is no improvement, we have to consider cow's milk protein allergy, in which case if the baby is breastfed, we will discontinue dairy products from the mother's diet. If the baby is not breastfed, we will consider an extensively hydrolyzed protein infant formula. Now, if there is also vomiting, hematemesis, irritability, crying, fussiness, arching back, failure to thrive, feeding problems, etc., we need to think of something more than normal G reflux and should consider eosinophilic esophagitis, anatomical abnormalities, etc. The management of regurgitation, as I just mentioned, are conservative, including positioning after meals and thickening feeds, which can decrease regurgitation in healthy infants. While frequent smaller volume feedings are sometimes recommended, there is little direct evidence to support the efficacy of this approach. And postprandial left-sided and prone position reduce regurgitation. However, prone position is not recommended for young infants because of the sudden infant death syndrome, so that is not a good position. So the baby should not be all day upright, should not be in car seats. It's better to keep them upright and not in chairs after feeding. And elevation of bed might be helpful in young babies, but the older babies will move around and then will not be useful. Well, the infant seat can also produce reflux, so that is not recommended. The effect of thickened feeds has been studied many years ago, 1987, as you can see in this study by Ornstein. And what you can see is that the emesis is reduced when you thicken the feeds, the number of regurgitation, and the volume is reduced as well. And also, gastric emptying is faster when there is a thickening. The efficacy of pre-thickened infant formula, this is a multi-center study, has shown again the benefits of reduced daily regurgitation in volume, the episodes of choking and gag and cough and trouble sleeping when adding formula with that has a thickener. It is not recommended to add cereal to the formula because it does not provide enough protein, it does not provide enough vitamins and minerals, and therefore is not a good substitute for pre-thickened formula. So there are many studies I can see that have looked into the effect of thickened feedings. In conclusion, this is the most recent study. This meta-analysis shows that thickened food is only moderately effective in treating reflux in healthy infants. Domperidone is not recommended because it can produce problems with heart rates and rhythm. So one should, if one has to use something, perhaps needs an electrocardiogram before and after the doses are started. It does not cross the blood-brain barrier, so as a law, the domperidone will not produce like pseudo extrapyramidal symptoms such as other drugs will do so. However, there are very few studies that have been done, and very few of them have shown that domperidone actually has any effect in controlling reflux. So this is essentially the diagram that I mentioned before, where we need to just go step by step and not accelerate the treatment. Don't start the babies on H2 blockers or proton pump inhibitors just right away. Now, if the baby has recurrent infants and it's an infant, again, are there any alarm signs? No, then it's a happy spitter. If yes, then we will see. But if if the baby is a happy spitter, we just need to reassure the parents there is no need to do anything. Formula with anti-reflux if the baby is not breastfed, and reassess at 12 months. If it has been resolved, that's everybody's happy. If it has not been resolved, then we'll need to do some further investigation. If the baby presents with irritability, then a possibility of reflux is a possibility not very high. And one could try either, if the baby is breastfed, as I mentioned, eliminating dairy products from the mother, or using a completely hydrolyzed, extensively hydrolyzed infant formula. However, don't expect results within 24 hours. It might take a week or more before the baby's symptoms resolve. So if the baby does not resolve with an extensively hydrolyzed formula, then other causes need to do. Now, the management of older children and adolescents. If you have a child that is an older child with heartburn or retrosternal pain or discomfort, if the symptoms are mild, you can do some life changes. If the child is overweight, have them lose some weight. Perhaps they are drinking a lot of acid coffee or tea or whatever, so you might modify that. But if the child does not improve, then you do a trial of acid suppressant medication for 4 to 8 weeks. Now, if the child has moderate or severe symptoms, then you go straight to acid suppression. And if the child has alarming symptoms like vomiting with blood or unable to eat, then that child needs to be referred to a pediatric gastroenterologist. And therefore, you move along depending on what happens. The child with dysphagia or adenophobia, empiric treatment for reflux, which lifestyle changes or pharmacotherapy are not recommended unless other causes of the symptoms have been excluded. So a child who presents with dysphagia probably needs to be referred to a pediatric gastroenterology for further evaluation. Further, patients should have a careful diagnostic evaluation, including an upper endoscopy, because eosinophilic esophagitis, peptic esophagitis might be one of the causes. More complicated is the respiratory symptoms with the gastroesophageal reflux. Patients with persistent moderate to severe asthma, particularly nocturnal wheezing, and clear symptoms suggesting reflux, including frequent heartburn or regurgitation, you can do a trial effective acid suppression for 4 to 8 weeks. And then you continue depending on the response. On the other hand, if the child does not have any evidence of reflux, then an empirical trial is not recommended, and one should go further by doing a pH probe or impedance to see if there is any evidence of abnormal reflux, in which case, then there might be a consideration to treat with proton pump inhibitors. If the child has recurrent pneumonia or aspiration, which is strongly suspected to be related to reflux, aggressive treatment is appropriate to prevent chronic progression of pulmonary disease. If pulmonary disease is mild, medical treatment with acid suppression can be used. If pulmonary function should be carefully monitored and followed up, but there are no definitive tests to determine whether GERD is the cause of recurrent pneumonia in a given patient. One has to keep in mind that children with cerebral palsy or neurological problems that have swallow impairment may also have aspiration of saliva, even if we do a gastrostomy and feeding them directly into the stomach. So they might continue to have pneumonia and aspiration, even if we bypass the mouth or we treat them with surgery to prevent gastroesophageal reflux. What are the other extraesophageal symptoms? Well, GERD is not a common cause of isolated childhood cough, except in those with neurological abnormalities that predispose them to aspiration. But many of the children with neurological abnormalities will have silent aspiration, that is not associated with cough. Stridor, hoarseness, sinusitis, and otitis media have been associated with GERD, mostly in case reports and case series in children. But neither the association with gastroesophageal reflux nor the benefits of a proton pump inhibitors have been well established in children. So here we have a cartoon of this cat and the lady via regurgitation. Remember to be very patient, listen to your patients, but not medicate unnecessarily or make infant formula changes or discontinue breastfeeding, because that's no solution of the problem. Thank you very much.
Thanks, dear Professor Lipschitz. I'm so sorry and sad for not having you right now here. Today we are having Dr. Pejman Rouhani, Pediatric Gastroenterologist and Associate Professor of Gastroenterology of Pediatrics at Tehran University of Medical Sciences. Dear Professor Rouhani, we are here with you. If you have any comments, please go on.
Thank you very much. Unfortunately, we missed Dr. Lifschitz, I think so. But I hope that we have it at the end of the session. And if there is a questions from the audience, I hope so that we have Dr. Lifschitz to answer the questions. I don't know, you have any new contact with him, and is there any chance to contact to come to the Congress, or it is not possible? As a matter of fact, I don't know exactly. If you have any contact, please tell us that he will coming soon or no, because maybe we have persons in the audience have some questions about the important meeting, as it is as about GERD is the very most common problem that children have. Okay, let's start with one of my best friend, Dr. Mahia, with Dr. Miqdady, who is one of the best pediatric gastroenterologists of the region of the world, and he is my great, he is one of my best friend and colleague in the region, and we collaborate with each other many times. Dr. Miqdady, you are so welcome. Thank you very much for accepting our invitation. We are so proud that you accept our invitation. Dr. Miqdady is one of the best pediatric gastroenterologists, who is the pioneer of one of the best sessions about pediatric gastroenterology. And the name of the Congress is Elite Congress. And we unfortunately missed Elite Congress in last 2 years because of the pandemic of COVID-19 infection. But I suppose we have it this year, and I invite my colleagues and friends all around the world to this great meeting. Dr. Miqdady will explain by himself. Of course, I do invite persons without permission from Dr. Miqdady. Thank you very much, doctor. We are listening, and we are hearing from ear to toes. Thank you very much. Please, welcome us, Dr. Miqdady, and present yourself. Thank you very much. Thank you.
Dr. Mohamad Miqdady. Dr. Miqdady is American board certified in pediatric gastroenterology, hepatology, and nutrition. He is the division chief of pediatric GI, hepatology, and nutrition division at Sheikh Khalifa Medical City in United Arab Emirates. Also an adjunct staff at Cleveland Clinic, Ohio, USA. Expert member of the Fishbone Council, Federation of International Societies of Pediatric Gastroenterology, Hepatology, and Nutrition, Malnutrition Obesity Expert Team. Dr. Miqdady completed his fellowship in Pediatric Gastroenterology at Baylor College of Medicine and Texas Hospital in Houston, Texas, USA. He held the position of assistant professor at Jordan University of Science and Technology in Jordan for 6 years prior joining Sheikh Khalifa Medical City. His main research interests include nutrition disorder, feeding difficulties, picky eating, obesity, procedural sedation, allergic disorders, and celiac disease. He has 19 publications in peer-reviewed journals. On the editorial, he is on the editorial board of a few journals, including Gastroenterology and Hepatology, reviewer for UpToDate.com. Dear Professor Miqdady, we are so proud to have you. Thank you very much for accepting our invitation and joining us. I'm sure that you are going to have an amazing educational lecture for us. Thank you for coming. Welcome.
Dr. Maya and Dr. Rouhani for the nice presentation. I assume you will run my pre-recorded presentation, is that correct?
And if you want, so we will play it, but if not, we can start your lecture live. Which one you prefer?
Please do the pre-recorded and I will be available for any questions.
Okay, of course. Dear Mariam, would you please share us his pre-recorded video?
Correct?
Yeah, I have your full screen.
Perfect. So we'll go ahead and get started.
Yeah.
Over the coming
Just a few minutes. Sorry.
Yeah, I'm really sorry. This is my bad. I'm gonna fix it. Just give me a minute.
Thank you, Maya. Thank you. Start.
Good afternoon, dear colleagues, and thank for the organizing committee for inviting me today to speak to you about a very important subject, which is the usefulness of fecal calprotectin. I understood from my colleagues that you as physicians at the Children's Medical Center and other centers as well are using this very useful tool to care for your patients, and I will be sharing with you some of the important information. Over the coming 25 minutes, I will share with you some background about the fecal calprotectin and its uses in different clinical scenarios in pediatrics. Before we get started, the first question, what is a calprotectin? Calprotectin essentially is a protein that belongs to the what's called the S100 protein family. This protein is very concentrated in the neutrophils, which is a subtype of the white blood cells. Whenever the neutrophils are concentrated in a certain area, this protein leaks out of the neutrophils and can be clinically useful as a marker for inflammation. All right, and this is calprotectin is present in all or almost all body tissues and body fluids. For example, it's present in the plasma. It's also present in the urine, CSF, in the stool. That's the topic of our today's talk. Also in the saliva, synovial fluid, and so on and so forth. All right. What's the biological function of the calprotectin? It has a lot of biological functions. Some of it is probably antimicrobial, antifungal. And the good thing about the calprotectin or the fecal calprotectin, it's resistant to digestion by enzymes or by other activities in the intestine, which makes it a stable marker that can be used for measurement of inflammation of the intestine. Also, it has roles in the homeostasis. It has a role in the cell proliferation and differentiation. It has a regulatory effect on the inflammatory markers and cytokines in the small intestine. All right. So whenever you have a disease of the bowel, which is a small or large bowel, there is a lot of inflammation there. The neutrophils, they come to the site of inflammation and they secrete this calprotectin, which can be measured in the stool as a non-invasive marker of inflammatory process. Excellent. Again, as I said, it's resistant to the degradation, which makes it stable even to 1 week at a room temperature. A lot of what I will talk about today is actually from a recent publication by the NASPGHAN that was published last year, talking about the usefulness of fecal calprotectin in pediatric practice. In their recommendation, they concluded 28 different recommendations. Of course, we don't have the time to discuss all of this, so I have highlighted for you the most important aspects of the fecal calprotectin that I believe it's important in clinical practice. Marker, it's simple to perform, and but we still don't have enough information about the normal levels in children. It can be very variable. I will show you some data to confirm that. For example, in this study, they looked at samples of fecal calprotectin from different children, and they said the minimum you need to do the test is 50 to 100 milligrams of stool. No matter which part of the stool you tested, it seems to be evenly distributed. So you tell the patient, send me any part of the stool, that's a good enough. And here they suggested that, again, it's stable for several days, even up to 7 days. And if you use the fridge or the freezer, it can be stable even for a longer period of time. So the first recommendation from the NASPGHAN group, you can collect the sample at any time of the day. It's different like the urine. The urine usually they say early morning. But for fecal calprotectin, it can be any time during the day. Keep in mind, if you are collecting the stool from the diapers, sometimes the water is absorbed to the diaper, and that will give a falsely increased level. So typically we tell the patient not to collect it from the diaper, or if it's from the diaper, to collect it before the water is absorbed from there, or you can inverse the diaper, the inside out, so it will not be absorbed if this is a young child. All right. Some of the cautions to be careful not to use any laxatives when you do that, because if you are using any laxatives, it will dilute the sample, and that might result in false decrease of the fecal calprotectin level there. All right. If you have any blood with the stool for whatever reason, remember that the fecal calprotectin comes from the neutrophils, and it will be falsely increased if there is any blood in the stool, especially if you have like hemorrhoids, anal fissure, or even menstruation blood. All right. In young children, the normal levels are very variable, and sometimes it's difficult to interpret these results. Again and again, fecal calprotectin is an inflammatory marker. The interpretation of the results should be put in the whole context of the patient. i.e. the history, the physical exam, the other lab testing, endoscopy if it was done to correctly interpret the result of the fecal calprotectin. The younger you are, the higher the fecal calprotectin. For example, in premature babies and infants in the first year of life, it can be high, and that is probably normal. Usually, the children will continue to have a higher level of normal fecal calprotectin till about the age of 4 years. After the age of 4 years, they have what the adults usually have. All right. This was published in the Journal of Cystic Fibrosis, and as you can see here in the interrupted line, they looked at children who do not have cystic fibrosis, children who are normal, and they measured their fecal calprotectin. As you can see very clearly that early in life, their fecal calprotectin level, the average was 100. However, there is some children and infants before the age of 2 years, they have a level up to 600, 500, 400 of levels of fecal calprotectin, and these are normal children. So in other words, a high fecal calprotectin in the first year or 2 or 3 or 5 can be absolutely normal, and they don't indicate any disease. Other causes of what I called it the benign causes of fecal calprotectin also is older age. If you are above 50 or 60, 70 years old, your normal fecal calprotectin is higher than the usual. Also, it's related to the physical activity. If you are an active person and you are doing some sports, your normal fecal calprotectin is higher. And that's probably related to the increased blood flow to the intestine there. Unfortunately, overweight and obese people are more likely to have a higher fecal calprotectin. All right. The second recommendation that I found it very useful is related to the fecal calprotectin and its relationship to taking medications. In particular, in this publication, they looked at non-steroidals, and they found that several of these non-steroidals can increase your fecal calprotectin. That's probably related to the injury of the intestine. For example, they talked here about ibuprofen, diclofenac, naproxen, and others. They can increase it. Aspirin also can increase it. And even in this study, they found that proton pump inhibitors like omeprazole and lansoprazole, they can increase the level of fecal calprotectin. So if you have a patient who's taking these medications for whatever reason, please stop the medication if possible, and then do the fecal calprotectin level. All right. The third point that I found it really useful in these patients is inflammatory bowel disorders. And actually, that was when all the science about fecal calprotectin came out. It's useful in the follow-up of these patients and to diagnose clinical remission. They found that if a patient fecal calprotectin is normal and they do not have symptoms, or they have minimal symptoms, this is a good indication of remission of the disease, i.e. the disease is under control. At the same time, if you have a patient with inflammatory bowel disease and their fecal calprotectin is increasing, you have to be careful that this patient is hitting to have a relapse of the disease. I highlighted here the level of 300. As you all know, the normal cutoff level for fecal calprotectin is 50. However, if it is less than 300, probably that's not important if you are dealing with a patient with IBD. So usually in my practice, I get worried if I have a patient with ulcerative colitis, for example, and their fecal calprotectin is more than 300. If it is 200, 150, 250, then I don't worry about that. And these are listed for you here, few of the publications about fecal calprotectin, and again, it confirms that it's related to the activity of the disease, and it's good for monitoring of these patients. However, if you have a patient with inflammatory bowel disease and he has a high fecal calprotectin, you have to look for other causes of increased fecal calprotectin, namely infections, or Clostridium difficile infection, or if they are taking any medications or any, because it can be only an inflammatory marker related to any of the above mentioned causes. The indication about infantile colic, the SPGAN group have concluded that this is not a good test for babies with infantile colic. Although if you have an inflammation of the intestine, it will be high. However, as I mentioned to you, the normal level for infants, we don't know it. So you cannot interpret the results in an infant with infantile colic. In functional abdominal pain, this is a useful marker of the disease, and it's a good reassuring test. I.e., if you have somebody with abdominal pain and you want to do for them fecal calprotectin, if the fecal calprotectin is normal in the right context, this very much rules out inflammatory bowel disorder. And this was confirmed back in the 2012 in a paper published at the Archives of Diseases of the Childhood. All right, good. Constipation, children with constipation, they might have increased the level of fecal calprotectin, but that does not help you in diagnosing or ruling out organic diseases like hair-sprung disease. So the SPGAN group, they did not recommend using fecal calprotectin in children with constipation. Cow's milk protein allergy. I will mention to you what the SPGAN says, then I will tell you what I have learned from reading many of these papers, which is a little bit different than the SPGAN paper. In the SPGAN, they said fecal calprotectin can be high in infants with atopic disease and allergic disorders like cow's milk protein allergy. They admitted that. However, there was no correlation between certain levels and the diagnosis of the disease. And the SPGAN, they said, is not useful as a diagnostic or a prognostic factor. However, let me share with you a couple of the studies talking about that. In this particular study published in 2010, the Journal of Pediatrics, they included 30 infants who are suspected to have cow's milk protein allergy, and they looked at them at diagnosis and 4 weeks after they have eliminated the cow's milk protein. And they compared them to healthy babies who do not have cow's milk protein allergy. They found that in children with cow's milk protein allergy who have hematochezia, i.e. blood with the stool, they have a higher level of fecal calprotectin. For example, the mean average was 325 versus the controls was 131. That's at the time of diagnosis. And when they put them on the elimination diet, the fecal calprotectin have decreased by more than 50%. So from 300 down to 157, and from 130 to 93. So infants who have cow's milk protein allergy, especially if they have blood in the stool, their initial fecal calprotectin is high, and when you put them in the elimination diet, it drops too high. So in my practice, I like to use it as a marker for improvement or response to the elimination diet. All right. How about cystic fibrosis? It was found that infants who have cystic fibrosis, they have a higher fecal calprotectin, whether they have pancreatic insufficiency or they have a normal pancreas. So this indicates that in patients with cystic fibrosis, probably they have some kind of an intestinal disease, an enteropathy of some sort that causes some inflammation of the intestine and increase of the fecal calprotectin. Acute gastroenteritis, fecal calprotectin can be increased in both viral as well as bacterial acute gastroenteritis, and it was not helpful to differentiate between them. So you can see a patient with rotavirus or adenovirus or whatever with a very high level, and this does not tell you if this is viral or bacterial infection. All right. I think I mentioned also that obesity can be associated with an increased level of fecal calprotectin. Again, if you read the literature about obesity, many people that these people, they have a low grade of inflammation, and that's the cause of their disease. Of course, that inflammation is mostly in the adipose tissue, and people with higher BMI, they have a more permeable gut, and that allows the flora and the inflammatory markers to leak to the bloodstream. All right. This is another study talking about obese children and fecal calprotectin, and they found that in this study that 47%, almost half of the obese children, they have a higher fecal calprotectin than their normal counterparts, and in about 1/3 of the patients, the level is doubled. If the cutoff is 50, this was 100 plus. All right, and in this particular study by Verdam in 2013, they found that the more obese you are, the more likely to have a higher fecal calprotectin. So the higher the BMI, the higher the fecal calprotectin. Okay. I think no, we talked about it. So. All right. I'd like to talk about necrotizing enterocolitis, and I'm sure that's the nightmare of any neonatologist taking care of premature babies. The SPGAN and NASPGAN have looked at several studies talking about necrotizing enterocolitis, and they concluded the following, and I think it's very important. First of all, they said sustained increase or a rising fecal calprotectin in a serial measurement might indicate a risk of developing necrotizing enterocolitis, i.e., if you are watching a premature infant and you see the fecal calprotectin rising or continue to be high, this might indicate that necrotizing enterocolitis is about to happen. Also, they concluded that the successive measurement of the fecal calprotectin is useful for the monitoring of the progression or the regression of the disease, i.e., when the fecal calprotectin start to come down, it might indicate the NEC is improving. So they recommended a serial measurement as a good non-invasive screening tool before the development of necrotizing enterocolitis. Okay, I think we talked about that. Yeah, this is the one I want to talk about. This study was published in Neonatology in 2012. They looked at very low birth weight infants, defined as less than 1,500 grams, and they looked at two groups: the one who end up having necrotizing enterocolitis, and the ones who did not have necrotizing enterocolitis. And they looked at serial measurements of the fecal calprotectin, and they found that the group who went on to develop necrotizing enterocolitis, their fecal calprotectin started to increase 12 to 48 hours before the onset of NEC. So what you can learn from this, that if you are watching a patient and his fecal calprotectin is going up, keep a close eye that this patient is more likely to develop NEC versus the other ones who will not develop NEC. And here they looked at specific numbers. They found that the ones who are going to develop NEC, they have a level from 200 to 400, while the healthy infants who will not have that is about 80 to 180, so almost double that. And then they, in this particular study in the Annals of Surgery, they used the cutoff point of 280, and they found that to be a fairly sensitive, fairly specific test. So if you have a premature baby and his fecal calprotectin is above 280, he is very likely to develop NEC, and that's fairly specific test. All right. They looked at the severity of the disease. There was no difference when it comes to the severity of NEC in fecal calprotectin. I think that's related to the variability that's normal at that age. So in summary of this study about NEC, they said a rise in fecal calprotectin at the onset of abdominal distension appeared to be indicative of development of NEC, and they suggested a serial measurement before starting or stopping the enteral feeds. I'll conclude by talking about autism, and I found this study to be really interesting, talking about autism. And they found in this study they looked at fecal calprotectin in infants with, in children with autism, and they found that 1/4 of the patients, 25% of them, they have a fecal calprotectin. That was published in 2010. And but there is another follow-up study done in 2016, published in JPGen. And this study, they compared autistic versus non-autistic children, but both groups, they have GI disease. And they found that if you have a GI disease, your fecal calprotectin is high, whether you are autistic or not autistic. So the increase in the fecal calprotectin is probably related to the GI disease, not to the autism per se. All right, and that's the Spigan conclude. So, ladies and gentlemen, over the last 25 minutes, I hope I have shared with you some of the important information about fecal calprotectin. I discussed with you the importance of age, and I explained to you that earlier in your life, your fecal calprotectin is more likely to be high normally up to the age of 4 years. We talked about different factors that affect that, like the microbiota and medications. Fecal calprotectin is very good for diagnosing and monitoring inflammatory bowel disorders and the prognostic factor for the development of relapses. It's a good test to reassure your patient that they have a functional GI disorder rather than organic. If you have somebody with GI complaint like abdominal pain, I shared with you some of the interesting information about the use in premature babies before they develop necrotizing enterocolitis. We did not talk about HSP because of the shortage of time. Also, I shared with you that there is some limited information in infantile colic. It's not helpful in the diagnosis. In constipation is not helpful. There is some value on cow's milk protein allergy, probably in following up these patients to see their response to the elimination diet. I shared with you that it does not distinguish between bacterial and viral acute gastroenteritis. And I wish we had time to talk about H. pylori, and acute appendicitis is not helpful there. I think with this, I will conclude my presentation, and I would be happy to share any questions. And I hope to see you all, inshallah, in Abu Dhabi on May 19th to the May 21st to join us for the Elite Pediatric Gastroenterology Congress. I'm sure many of the audiences today, they have participated in our previous 7 congresses, and I hope to see you again in our 8th Congress. Thank you very much for being a great audience, and I will be available for any questions. Thank you.
Thank you so much, dear Professor Miqdady. It was really educational lecture. I learned a lot, and I have questions, and also I can see questions in the chat box.
I'll be very happy to answer them.
Okay, dear Professor Rouhani.
No, Dr. Rouhani should not be allowed to ask. He will ask difficult questions.
Thank you very much, Dr. Miqdady, for a nice presentation. As always, we learn a lot from you. Thank you very much. It was fantastic. Dr. Mahia, would you please ask the questions in the audience? And if you have any question, please.
Yeah, of course. Can fecal calprotectin be used for diagnosis of gastric malignancies?
Unfortunately, no.
Okay.
It's not a good screening test.
My own question. Should fecal calprotectin be in the list of routine lab tests in infants?
Routine?
Yeah.
It depends what disease you are looking at. But keep in mind, as I mentioned, normal fecal calprotectin in infants is higher than the adults, and it normalizes by the age of 4 years. So if your lab tells you this is high, you have to read it in relation to the age. Below the age of 4, it's high. In infants in particular, it's very high, can reach 400 or 500, and that can be absolutely normal.
Can we have a normal range of fecal calprotectin in infants or no? It's different.
In infants is higher, but after the age of 4, you use the cutoff point of 50.
Okay, thank you very much.
Sure.
Dear Professor Rouhani, now
Is there any
if you
questions
have
from the audience?
no more
No
questions.
questions?
No
Okay.
more questions.
When there is no
Thank you
question,
very much.
two things.
Thank you. And
thank-
best of luck.
Thank you very much, Dr. Miqdady. Would you please stay with us if you have time until the end of the session, because many of the colleagues maybe have questions at the end. Thank you very much.
Pleasure. Thank you.
It was a great pleasure to meet you here, and I hope to see you very soon, healthy and strong. Thank you very much. Thank you very much for attending.
Thank you, Dr. Professor Miqdady. And now we will go on to the next lecture by our dear Professor Rouhani. Dr. Pejman Rouhani is pediatric gastroenterologist, assistant professor of pediatric gastroenterology, chief of hepatology and enterology research center, and deputy director of the Second Children's Medical Center Hospital, Tehran University of Medical Sciences, Tehran, Iran. Previously, he was as assistant professor of pediatric gastroenterology and research director of Mofid Children's Hospital, Sheikh University of Medical Sciences, Tehran, Iran. We are going to have an amazing lecture by dear Professor Rouhani on approach to vomiting in pediatrics. I think so.
I have to start to sharing.
Yeah, it would be more than grateful if you start sharing your slides.
Let me do something for that. What I have to do for this? Let me do it again. I think we have the same problem that we had before.
Is there anything I can help you, dear Professor?
I want to share the screen, but I suppose that if I do this, you can see just whole slides, and maybe I can do this here.
Yeah. There isn't any more errors now.
How is that? Is it right now?
No, not yet.
How about now?
You are not sharing the screen.
Okay.
That's great.
It's okay?
Yeah, that's okay.
Thank you very
Let's
much.
get started. Thank
Sorry
you.
for a delay, as a matter of fact. Okay. Thank you very much. First of all, I want to thank Dr. Aghai, who is the chief and executive secretary of this great event in Iran, and he is one of the best cardiologists of pediatric cardiologists in Iran, and one of the best and known in the world. Thank you, Dr. Miqdady, for all your efforts to have this international session with the other colleagues from the other parts of the world. It was fantastic. And after that, I want to thank my colleagues and my dear friends who accept our invitation to be part of this great event. As Professor Carlos Lifschitz, unfortunately, we lost him. And after that, I'm very thankful to Dr. Miqdady accepting our invitation. And thank you very much for a nice presentation. And in addition, I'm very, very thankful to Dr. Chris Tzivinikos for accepting our invitation for this great session, and we will hear from him very soon after my presentation. I want to talk about the approach to the vomiting in children. I'm Dr. Rouhani, and I'm Professor of Pediatric Gastroenterology in Pediatric Center of Excellence, Tehran University of Medical Sciences. Okay, I'll have to go to the another slide. All right. Okay, our objectives are first, understand the main pathways that trigger vomiting via the emetic reflex, and differentiate among acute, chronic, cyclic cause of vomiting, and create a broad differential diagnosis for vomiting based on patient history, physical examination, and age. Recognize red flag signs and symptoms of vomiting that require emergent evaluation, and recognize when to begin an anti-emetic medication. Select anti-emetic medications according to the PRISM underlying mechanism of vomiting. As all you know, vomiting or MS is a complex reflex behavioral response to a variety of stimuli and has three phases. The first phase of vomiting is a prodromal period, we call it nausea, and is a sign of autonomic nervous system activation. Probably, of course, we do not exactly know the mechanism behind nausea, as a matter of fact. The second phase is retching. As Dr. Carlos Lifschitz told us, retching is a coordinated and simultaneous contraction of abdominal muscles in addition to diaphragm and closing the epiglottis and upper esophageal sphincter to provide a great and huge pressure in the abdomen. This pressure help us to forceful expulsion of the stomach contents through the oral cavity. Two important terms that we have to differentiate from vomiting, as Dr. Lifschitz told us, as vomiting and regurgitation. As you know, all regurgitation is an effortless reflux of the intragastric contents, and there is no neurotic pathway involvement in production of the regurgitation, and is completely restricted to GI tract in comparison to vomiting. And vomiting also different from rumination syndrome, in which its patients self-promote, electively regurgitate, maybe chew it out and re-swallow or regurgitated food again. And this is something happened to some of the patients, and we have to differentiate this from vomiting, because the patient with rumination is completely aware of what he do, and it's very important in comparison to vomiting that patient didn't know anything about and is unconscious about the vomiting that happens. If you look at this nice picture from one of the best articles we had 3 years ago in JPGN, published about anti-emetic medication about the vomiting, as you can find a reference after this slide. And you can see that there are many centers in the body that have receptors for activation of vomiting. The first one, as you can see, is gastrointestinal tract and heart, and we have mechanoreceptors and chemoreceptors, especially 5-HT3 receptors and cannabinoid 1 receptors in GI and heart for activation in the vomiting center. If you look at the vestibular system, as you can see here, we have H1 receptors and acetylcholine M1 receptors here. And in central nervous system, we have cortex, thalamus, hypothalamus, and meninges have the same receptors for activation of the vomiting. And in addition, we have two central parts for especially for vomiting, as one of them is the chemoreceptor trigger zone, as we call it, CTZ, and area post rema, or the floor of the fourth ventricle. And in that center, you can find chemoreceptors, T2 receptors, neurokinin 1 receptors, and 5-HT3 receptors there. In addition, we have a chemoreceptor trigger zone who has some kinds of receptor as H1 receptors, acetylcholine muscarinic receptors, neurokinin 1 H1, and 5-HT3 receptors type 3 there. These are many different types of receptors that you can see. We have that they help us to, they help the body to, the physiologic response of the body to noxious stimulus as vomiting. As you can see, why are they very important for us? Because if we want to manage the vomiting, we should know exactly what is the mechanism behind of this vomiting. For example, if you have a vomiting with source of vestibular system, and if you prescribe a medication with, for example, D2 antagonist activity, the patient doesn't benefit from that, because we have to keep attention about M1 and H1 receptor in that kinds of patient. If you want to look exactly through the details, you can see here more. And we have 4 category of main category for production of vomiting in the body. First of all is, if you look at here, you can see that vagal afferent nerves come from mechanical stimulation in any parts of the GI tract. And we have here toxic stimulants that they provide chemoreceptor trigger zone directly and stimulate that for providing vomiting. And in addition, we have motion center, motion as a leader of the vomiting with vestibular pathway receptors as M1 and H1, and we have emotion as another part. For example, there are many children that, for example, they smell and something and they have a vomiting after, or a sense of nausea after that, and this is exactly straight go to the central processing unit of the brain, and after that make the nausea or vomiting. As you can see, if, for example, many of patients, we have anxiety, for example, during examination or depression or any kinds of anxiety, as a matter of fact, or obsession, and many of them care about many of the jobs they have to do, and they have fear about the jobs that they have to do, and this fear may predispose them to anxiety, and maybe this emotion provide vomiting, for example, before the examination, as a matter of fact. Then we can see that 4 main groups of stimulus for vomiting in all around in all parts of the body. But how we can differentiate the etiology? The best way we can differentiate the etiology is attention to the temporal pattern of vomiting. As you can see, we have 3 kinds of temporal pattern. As you can see, one of them is acute one. The most common cause of vomiting are acute, as a matter of fact, and most of the time they're moderate, or sometimes they're severe, and vomiting intensity is moderate to high. And as you can see, there is no recurrence rate, and the onset is variable. Maybe the vomiting is in the morning, maybe it's in the night, maybe in the early afternoon. We do not know exactly what is the onset in acute patients, and acute patients has vomiting during 4 to 5 days, as a matter of fact, from onset to 4 to 5 days. Some references tell us the acute is for 1 week, as a matter of fact. And maybe the patient have associated symptoms as fever, diarrhea, or maybe there is a history of household contact with another person. And one of the most common cause of acute vomiting is viral infections. Of course, infections are the most common, and viral infection are the most common cause of these kinds of infections. As you know, infections have different effect on GI tract. Some of them directly inflame the mucosa of the stomach and produce gastritis or gastropathy, and some of them may provide gastroparesis. For example, COVID-19 infection is one of the most common cause of gastritis or gastroparesis, and we see these kinds of patients these days many times. And for example, H. pylori infection is another cause of gastroparesis, or rotavirus can do this. And we can see this sometimes that the time of the duration of these kinds of vomiting maybe last 1 year, as a matter of fact. But after the taking care about the infection involves the GI tract, we have to keep attention about the infections out of the GI tract. For example, UTI, pyelonephritis, or sometimes meningitis or otitis media are the other kinds of infection that may produce vomiting, as a matter of fact. After infection, the second most common cause of acute vomiting is intoxication, maybe sometimes intoxications with drug or medicine, or sometimes with heavy metals, as a matter of fact, as a source of intoxication. In addition, we have to keep attention about of the patients who have just vomiting and there is no diarrhea or any associated symptoms. In these kinds of patients, we have to ask caregiver about something as a blunt abdominal trauma is very important, or maybe head trauma is very important. For example, a head trauma, and in addition, maybe a foreign body ingestion. These are something very important, but sometimes we miss. and maybe we send the patient to the home and say, okay, it's a common infection, and after that we see the patient with a very great complication after that. It means that we have to care about vomiting, especially if it is isolated. After these important things, that we have to keep attention about metabolic causes of vomiting in acute vomiting. For example, maybe this is the first presentation of patient with diabetic ketoacidosis, or maybe the first presentation of uremia as the first presentation with acute vomiting. This is very important. We have to keep attention about the reasons of acute vomiting. If you want to go to the chronic recurrent vomitings as the most common form of the chronic vomiting, 2/3 of the chronic vomiting are chronic recurrence. And in comparison to cyclic recurrence, as you can see, we see that the vomiting intensity is low, 1 or 2 MSS per hour at peak, and no stereotypy, most of the time in daytime, and associated symptoms like abdominal pain and diarrhea are common, and no household contact affected, and the family history of migraine is something around 40% positive. In addition, the most important cause of chronic recurrent vomitings are in GI tract, as a matter of fact. We can look at this slide for the causes. If we put it in a nutshell and summarize the causes of GI tract as a cause of vomiting, as you can see, mucosal reasons are esophagitis, gastritis, duodenitis, and colitis. What we can do to diagnose these? The best way of diagnosis of esophagitis, gastritis, duodenitis, or colitis are hepatology and endoscopy. And how about the visceral reasons of the GI tract? If you care, you can find cholecystitis, pancreatitis, hepatitis, renal stone with ultrasound of abdomen, and in addition, some lab data, for example, as AST, ALT, amylase, lipase, and some kind of these investigation. You can understand how is the visceral reasons are important in the production of the vomiting. And in addition, another cause of the vomiting are anatomical reasons that they provide obstruction partially or totally in GI tract. There are many different kinds of obstructions, from oral cavity to the anus, as a matter of fact, but HPS, hypertrophic purulent stenosis, antral web, duodenal atresia, ileal atresia, colon atresia, many other abnormality in the GI tract predisposed patients. For example, maybe have a patient with Crohn's disease who have a stricture, as a matter of fact, and there are a lot of reasons for stricture and stenosis in the GI tract. They are the main cause of anatomical one, and they can provide vomiting for us. But for investigation of these reasons, we have to care about the graphies with contrast or without contrast. And about this motility reasons of the GI source of the vomiting, you have to keep attention about, for example, the most common one is GRD and eclasia, gastroparesis, ileus, or SIPO. As you can see in the slide, there are different parts of the GI tract could be involved with this motility. For example, the most common one is GERD, as we classify GERD many years ago as an acid peptic disease, but now we consider it as a dysmotility disorders mainly. In addition, we have eclasia. As you know, if the body of the esophagus and the ileus doesn't work properly with hypertensive pressure, and gastroparesis, as I mentioned before, and ileus, if you have any activity in the small intestine, or SIPO as a chronic intestinal pseudo-obstruction syndrome, when there is a dysmotility in any parts of the colon or sometimes in small intestine. These are the reasons that if you want to know the reason of the vomiting is these, we have to consider manometry as one of the best way to diagnose. Maybe the other ways cannot help us to understand what are the most important reason. And cyclic recurrent vomiting, as a 1/3 of recurrent vomiting, are most of the time severe. Most of the patients are dehydrated and should be hospitalized because they have a high MSS per hour, something around 6, 10 in hour. Maybe the patient have vomiting. In addition, the recurrence rate is completely infrequent, and stereotypy is very common in these kinds of vomiting, as a matter of fact, and the onset of the vomiting is maybe in the middle of the night or early in the morning. Associated symptoms like pallor, lethargy, nausea, abdominal pain, household contact, of course, is not. And we have to care about the family story of the migrant. More than 82% of the patients maybe have a positive family story. Of course, if you care about the cyclic vomiting syndrome or abdominal migraine, more than 95% of the patients have family history positive from, as you know, because we suspect the mitochondrial disease on the basis of these disorders. The inheritance is maternal, and we have to ask about these conditions in mother or in grandma or in aunts, as a matter of fact, and these are important. And most of the time, the cause of the cyclic recurrent vomiting are not GI tract, and most of the time is out of the GI. The most common reason for that is, one of them is chronic sinusitis in children is very important. We have to keep attention about PND, post-nasal discharge, as a reason of the chronic cyclic recurrent vomiting. And in addition, we have to keep attention about space occupying lesions in the brain. Of course, these lesions may provide chronic recurrent, or anyway, maybe sometimes provide cyclic recurrent, and we have to keep attention and do something about that. For example, maybe we investigate with MRI of the brain. In addition, we have to keep attention about metabolic disorders. For example, if the child have a great vomiting after a special kind of a meal, we have to attention to, for example, organic acidemia, urocycle defects, many kinds of metabolic disorders can provide this, and we have to keep attention about that. And in addition, some functional gastrointestinal disorders, we call it FG, functional gastrointestinal disorders, may predispose patient to cyclic recurrent vomiting. These are as chronic idiopathic nausea. As you know, is teenage girls, they have some kinds of recurrence of vomiting, maybe early in the morning. And in addition, maybe have abdominal migraine or CVS, cyclic vomiting syndrome. And these are the functional gastrointestinal disorders that we cannot say at first as a diagnosis. We should exclude other causes and other reasons. And after that, we can say we consider these as a cause of the chronic cyclic recurrent vomiting. And if you want to go briefly to the assessment of these kinds of patients with vomiting, we have to care about medical history and physical examination, asking about the characteristic of MSS. When did it begin? How often does it occur? Has it happened before? Is it forceful or effortless? Does it contain bile or blood? With food and food ingestion and vomiting. And is abdominal pain present, headache or mental status change, family history of migraine, vomiting that awakes a child from sleep? They are very important that we have to keep attention about them. And post-tussive MSS is very important because we have many consultation about the vomiting in patients who have cough. And after the episode of cough, they vomit, as a matter of fact. Of course, in this situation, we keep attention about the reasons as GI sources of the vomiting, but most of the time, we cannot find any GI sources. Red flags and signs and symptoms are very important. You should, when we face these signs and symptoms, we have to keep attention about the main reasons, and it's a danger sign in addition to warning sign. As hematemesis is very important, hematochezia is very important, and recurrent bilous emesis, clinical dehydration, evidence of shock, focal neurological changes, and abdominal distension, vomiting that wake a child from sleep. These are very important red flags that we have to keep attention and taking care about the patients if the patient have these kinds of symptoms, and very important that we have to give this clues to our junior students when one day want to approach to vomiting in emergency ward. How investigate the different types of vomiting? As you can see, in acute patients, we have to keep attention about electrolytes, BUN, creatinine, abdominal radiograph, and maybe in chronic one, we care about was again, BUN, creatinine, celiac screen, amylose, lipase. In some situation, urine beta-hCG, hepatic function panel, stoolage pylori antigen, upper endoscopy, brain MRI, or sometimes in recurrent cyclic vomiting, we have to keep attention about BUN, creatinine, glucose, upper GI series, serum amino acids, urine organic acid, urine ketones, carnitine profile, ammonia, lactate, pyruvate, and ultrasound of the abdomen. These are many important things that we have to do in approaching our patients as a laboratory workup. Sometimes we need in some situation, as a matter of fact. But how about the treatment? For treatment, we have to keep attention that the first step in managing vomiting is clinical stabilization and emphasis on correction of fluid deficit and electrolyte abnormalities. And the second important one is identification and correction of the primary problem. It is very important that please don't administer any medication to the patient with acute vomiting. Please, this is very important because the patient should have many episodes of vomiting that predispose patient to dehydration, as a matter of fact. But the reason of the vomiting is the most important things that we should find first, and then we have to try to do something for the patient, as a matter of fact. We know that many of the parents are agitated when bring the children to the emergency department, and maybe physicians are under stress to use the antiemetic medication for these kinds of patients. But we have to explain, reassure the parents, and good physical examination and good history taking maybe help us to understand what is the reason behind, and then just without any medication or therapy, maybe the vomiting is stopped and we do not need to go to another medication. Okay, and if I want to say briefly about the medication we have, if you look at this, ondansetron is a very, very famous medication for with antiemetic effect, and the most adverse effect of ondansetron is, as you know, is diarrhea. But we have to keep attention about some side effects of ondansetron, especially when you use it in IV form of the medication. And it is very dangerous if you inject it fastly, and maybe it prolongs the QT and maybe predispose your patient to arrhythmia. And it's very important. Please take care about the ondansetron. And in addition, taking care about the other medication we used in addition, because drug interaction is very important in these kinds of patients. If you use ondansetron, maybe some of the other drugs prolong the QT, and both of them predispose patient to torsitopointis as an arrhythmia. And it is important anyway that we stop medication until we sure that the patient should give this medication. And ondansetron is a very common use in Iran, and we have to aware that ondansetron maybe have some side effects. Granisetron is the same drug and with the same side effects. It's most of the time we used it as a drug for controlling post-chemotherapy nausea vomiting, as a matter of fact, and it's very effective in patients with post-chemotherapy nausea vomiting. And as you know, post-chemotherapy patients have two kinds of nausea and vomiting. One of them is early one, and the other one is late one. And the ondansetron or granisetron doesn't have any effect on the late one, and just have effect on early one. And we have to use some other medication to control the vomiting after post-chemotherapy as a late one. And we can use a cyproheptadine as a drug, and especially cyproheptadine as a side effect, it stimulates appetite, and we have to keep attention about the side effects and have a great drug interactions with many other medication. Please be aware that it's one of the best drug with H1 blocker effect, control the abdominal migraine or cyclic vomiting syndrome, especially in children under 5 years of age, and it's the drug of choice in this situation. Amitriptyline is another drug for controlling attack of abdominal migraine or cyclic vomiting syndrome. We use it as a first choice of drug to control these attacks in children. Of course, not the attacks, for prevention of these attacks. Amitriptyline is a choice for in children more than 5 years of age. And but we have to keep attention about the cardiac arrhythmia effect, and in addition, a sedative effects that amitriptyline has. And we should keep attention that we have to use this medication before the bedtime, as a matter of fact, because if you give the patient in the early in the morning, maybe the children cannot go to the school and keep attention about the lessons from the teacher, and this is very important. We have to use it at the night. And erythromycin is another multi-link drug. It's give you a chance to improve pyloric stenosis and gastric emptying, as a matter of fact, but erythromycin has side effects as QT prolongation. We have to keep attention. Drug maybe predispose our population to antibiotic resistant microorganism, and it's very have to keep attention about that. And unfortunately, when you use erythromycin during the days, the tachyphylaxis happen and the effect of medication stop, and this is another side effects of erythromycin, as a matter of fact. We have difenhydramine. Difenhydramine is H1 blocker. It's a very famous one. As you know, we have the tablet form of this drug as a dimenhydrinate, and we use it in motion sickness, and it's very effective. But difenhydramine is a sedative drug, and we have to keep attention about using in children, but it has a very good effect on vomiting, especially with H1 and T2 blocking effect that we have with difenhydramine. Promethazine is another medication, and it's from as in tranquilizers and neuroleptics medication. As you know, promethazine is contraindicated in children under 2 years of age because of respiratory depression, because of sedative effects, as a matter of fact, sleep apnea, and promethazine should be very cautiously used. We do not use it as a main medication in controlling the vomiting, but it's really effective, as a matter of fact. We know that, but we have to keep attention about the side effects of neuroleptics as promethazine and prochlorperazine, and this is the same D1 and D2 blocker, the same as promethazine. They are the Ozing group of medication. They are neuroleptics, and we have to keep attention about the side effects, especially they goes through the blood-brain barrier, and sometimes we have extrapyramidal reaction with these two kinds of drugs. And meclizine, we have it in Iran as ciclizine or cynarizine. It's another drug. It's very effective for children more than 12 years of age in abdominal migraine or cyclic vomiting syndrome, as a matter of fact. And the other drugs, if I want to go, I know, Mahia, I'm run out of the time, I suppose. Okay, I'm very fast.
Yeah, I was going to notice, make you pay attention to the time.
Yes, thank you very much. This is the last slide, and just go through it very fast.
Sorry for interrupting you.
Thank you. Metoclopramide is another medication. It's very important. You know, in Europe and in the United States, it's in black box warning. Keep attention about the side effects as extrapyramidal reaction and Parkinsonism, like tardive dyskinesia, tremor, and we have to keep attention, but it's very effective. And according to the European guidelines, we can use it just for 5 days in a therapeutic range of, as a matter of fact, and maybe it will be safe. But keep attention about the QT prolongation and other side effects because metoclopramide is another. We know that it's a part of the benzamide group, and it's very important, and maybe is an arrhythmogenic drug. We have to keep attention about it. Scopolamine is another one. It's M1 blocker. We cannot use it as a tablet. We use it as a transdermal patch. It's very effective in children who are candidates of surgery and for controlling post-operation nausea, vomiting. And apripitone, as a last one, is one of the famous drugs controlling vomiting, especially in late onset vomiting of post-chemotherapy nausea. Vomiting is very effective, and maybe is a little expensive, but it's very useful, and it's not common to use it in many situations. Especially it's good for patients. We do not use it as a chronic medication. We use it just for episode of chemotherapy, and it gives us the chance to stop the annoyance of the vomiting in children after post-chemotherapy, and it's a very effective drug. Thank you very much for your attention. I'm run out of the time, and please Mahia, I'll continue. If we do not have any questions, we go fast to Professor Chris, and we face after the end of the session, we answer the questions if you have.
Thank you, dear Professor Rouhani. We have too many questions in the chat box, and I think we can have an open discussion part at the end of the session about nausea and vomiting in COVID-19, and also we will have dear Professor Abai to discuss about myocarditis and the indication of EKG to give ondansetron to patients. Dear Professor Tzivinikos, thank you for joining us. So many thanks for accepting our invitation. Such a great honor for us to have you in our session.
Thank you very much for the invitation for Professor Rouhani. I'm not a professor, by the way. I only work for the university in the Mohamad bin Rashid University. I work in Jalila Children's Hospital. I'm very delighted to participate in your nice meeting, and I enjoy the lectures.
Thanks for introducing yourself. Dr. Christos Tzivinikos is a consultant pediatric gastroenterologist, adjunct clinical associate professor at MRBU or MBRU. He completed his entire general and subspecialty pediatric training in the United Kingdom. He is an elected fellow of the Royal College of Pediatrics and Child Health in the United Kingdom prior to joining Jalila Children's Hospital. Dr. Christos has vast experiences in running comprehensive multidisciplinary feeding clinics for children with neurodisability and congenital heart disease and other chronic diseases. Dr. Christos was the chief of Pediatric Gastroenterology Division at Alder Hey Children's Hospital in Liverpool, one of the largest pediatric hospitals in Europe. And he is an elected member of Second Gastroenterology Committee 2018 to 2024, as well as an active member of the Second IBD, eosinophilic GI diseases, and endoscopy working groups participating in the development of new and up-to-date guidance for the management of GI disease in children. I'm really sure that we are going to have an amazing educational and particular lecture based on the newest updates on SPECON guideline, as I know.
Thank you very much for the nice introduction. When I received this invitation, I saw your title of your conference, which goes with updates in various pediatric specialties. So I thought one of the topics which participate also in SPECON is the eosinophilic esophagitis, and the landscape is constantly changing over the last 20 years. I think now SPECON is about to publish the next few months the updated guidance in the eosinophilic esophagitis, and I thought that would be nice to give an update for the audience and the colleagues. Is my share screen? Can you see my slides?
Yes, dear Professor, that's perfect. Let's go on.
Right. Okay. So without further ado, I'll present you mainly a sneak preview of the 2022 SPECON EOE guideline, which I'm also participating in the group, and I'll go through a little bit historically. About 9-10 years ago, initially the group in SPECON started forming about eosinophilic esophagitis, and then also we had the first papers published in 2013, and then we had the first position paper was also published in 2014 as sort of a guideline. Then we had a big adult and pediatric meeting around 2018, and this is a publication there. It's called AGREE, Conference or Meeting Proceedings, where the definition and the main management sections of eosinophilic esophagitis were revisited, and you can see here the overview. Eventually, over the last few years, we understand more about the disease. We have mainly 3 endotypes now identified, which have specific associated with specific genetic polymorphisms. This endotype 1, which a lot have come across in pediatrics as well. We have a normal looking esophagus, but there is eosinophilic infiltration in the mucosa. We have the inflammatory endotype, which is the commonest we see in kids. And as you go towards adolescents, you have the endotype type 3 in adults. You have the narrow and fibrostenotic endotype. Now we know that eosinophilic esophagitis is going through a sequence of inflammation, and the fibrosis starts developing if you don't treat properly, and eventually you get the stenosis. As you can see, this sequence is more frequent in children who have inflammatory endotype, as I said, and then going to the adults and adolescents, you have more, the fibrosis and the stenosis. And this is the typical endoscopic pictures we see. Starting from the top left, you see the edema and the hyperemia, the micro abscesses, and the exudates, the typical trachealization and firing on the esophagus, and even worse, you have the stenosis. And this is the last picture is after dilatation. Now, the first of all on the group to work on the guideline was to outline and make clear the definition. And this is something now, two main components of the definition, which I want to emphasize. This is a chronic disease, okay? This is not something which comes and probably will give some treatment and will go away. Unfortunately, it's a chronic disease. It can progress even to fibrosis, as I showed in the previous slides. And this is because of immune antigen non-IgE mediated esophageal disease. This is important because you will see one of the major differences in the new guideline is the allergy testing, which we'll spend some slides there. It's a non-IgE mediated esophageal disease, characterized clinically by symptoms related to esophageal dysfunction, and histologically by this hallmark of the disease, which is the eosinophilic predominant inflammation, more than 15 eosinophils per high power field. And when we're talking about esophageal dysfunction, we mean the classic dysphagia we see more in older children with the classic food impaction presentation in the medicine department, or food stuck during swallowing, and they have to drink a lot of water. Classically, chicken I have seen, and steak and bread crust, choking on the food. But we have more symptoms, vague, I would say, or overlapping with other diseases like gastroesophageal reflux, as we listened from the Dr. Lifschitz on the first presentation, and with Professor Rouhani with the vomiting, reflux symptoms, abdominal pain and vomiting in younger children, which is very difficult to distinguish between the gastroesophageal reflux or eosinophilic esophagitis. Now, a lot of these kids we see, especially in the feeding clinics, or the aerodigested clinics we run in Jalila Children's Hospital, they have abnormal compensatory eating behavior, meaning slow eating, they chew excessively. So they try to compensate with the dysphagia. They feel a lot of toddlers or even children 4 or 5, they cannot verbalize these symptoms, or they cut food in small pieces, drink a lot of water. So all these are part of the esophageal dysfunction. Of course, finding eosinophils in the esophagus is not only eosinophilic esophagitis. We have to think about the differential diagnosis, or such as gastroesophageal reflux disease. Now, the term which we used to have in the previous guidance and now has been abolished the last few years, not by the adult guidelines, I have to say, but clearly on the pediatric guidelines, is the PPI responsive esophageal eosinophilia, which now actually is a subgroup of the eosinophilic esophagitis. Celiac disease can also have eosinophils in the esophagus, Crohn's disease in particularly, eosinophilic gastroenteritis when we have more eosinophilic inflammation in other parts of the GI tract, hypereosinophilic syndromes, achalasia itself because of stasis, and more rarely graft versus host disease, vasculitis, and others. Now, talking about diagnosis, I think the statements now are clear, and a lot of colleagues have adopted this practice over the last few years. We need an endoscopy and biopsy. Unfortunately, we don't have biomarkers as we at present to diagnose or even monitor the disease, remotely or without endoscopy and histology. So we need at least 2 samples from each level of the esophagus, lower, mid, and upper. So at least 6 biopsies in order to be sure we catch the eosinophilic esophagitis. And then if you have suggestive symptoms, regardless of endoscopic appearance, you have to do the 3-level biopsies of the esophagus. I don't regard this as a burden for the patient. It may be a burden when you work in the private health system with the biopsies. What I do in order to pass this problem, I do the 3 levels and I put in the same pot. But this is something we have to think in order we put the children under GA. We suspect even the reflux or the Untitled vomiting. Even if it looks normal, I think it's important to do your threshold of the 3-level esophageal biopsy has to be much lower than it used to be. So what's talking about endoscopy, adults have developed a very nice eosinophilic esophagitis endoscopy score in order to use, the assessment and as a predictive value for the eosinophilic esophagitis patient. However, in kids, it still has to be validated. So, and on its own, I cannot use it at the moment as a sole diagnostic or prognostic marker of eosinophilic esophagitis. Now, talking about histology, again, we have the standard of 15 eosinophils per high power field in esophageal biopsy. It's fairly highly sensitive and specific as a cutoff value in the esophagus. Again, we have the eosinophilic esophagitis histology, histological score, but again, in children needs further evaluation. As you can see, the particular EOE histology score is not only about counting eosinophils. There are so many components there which have to be addressed. And this is time-consuming histopathologist. You have to have a very good relation with your histopathologist in order to make you the score. I do this as a part of the ESPAGAMP registry. I ask for this when we have eosinophilic esophagitis, but still is because of the registry, and we have to learn more about this and validate the children. So this is all these components, how they look on the microscope of the histopathologist. Now, another issue which comes with with the histological diagnosis is a lot of histopathologists or histopathology labs or microscopes, they don't have the same reference what it stands for the histology for the high power field. Okay, so ideally the group felt that it depends on the histopathology lab. We need to have a provision of conversion tool to clarify the laboratory if the high power field is 0.2 or 0.3 square millimeters. So that's important for research mainly, but for consistency, this has to be applied in order to have the same results as reference. Now, another big issue with eosinophilic esophagitis, and this is one of the biggest changes the last few years. As I said, it's very clear now that we are talking about a non-IgE mediated allergy, food allergy in the esophagus. So with that notion in mind and this knowledge about the pathophysiology, now the allergy tests have gone actually out of fashion. I'm not saying they're never used. I will mention when actually they may be used. But the targeted elimination diets we used to do based on RAS test or skin prick tests, they are not recommended anymore. Identifying EOE triggering foods has to be done by an elimination diet and consequent reintroduction of single foods under biopsy control. So the ESPAGAN eosinophilic esophagitis group does not recommend the use of available allergy tests. IgE particularly is not for targeting, the elimination diets you do. They may have a role identifying particular patients who are at the risk of immediate type hypersensitivity reaction prior to the food reintroduction phase or following prolonged elimination. There have been some cases where, for example, they didn't take wheat for a long time and they try to reintroduce, and then there is an allergic reaction. So the eosinophilic esophagitis patients, they can have concomitant true IgE food allergy. but the disease itself is not an IgE-mediated allergy disease. So these tests are not routinely recommended. Of course, you will have the patient with a lot of atopy, with asthma. There is a lot of anxiety there to check for food allergy or eczema. That's another disease which is affected by IgE-mediated allergies. But for the EOE as it stands at the moment, with all the evidence combined over the last few years, atopy patch tests, IgE tests, and even worse, IgG4 tests, which I'm pretty sure you have seen coming from usually private clinics with all these 6 pages of 10 pages of foods, 20, 30 foods allergic, and then it's nightmare for the parents and everybody. So talking about the treatment for eosinophilic esophagitis, we treat because we want symptom reduction, we want to avoid the food impaction, we want to prevention of esophageal fibrosis and the remodeling from the inflammatory state to the fibrotic state I showed you on the previous slides. We have various drugs, topical steroids, PPIs. We have now a new kids on the block, the biologics, which are coming, still in pediatrics in the embryonic stage, but soon they will come. And we have, of course, the classic diet. And if unfortunately we have a stricture, we need a dilatation. Now, talking about diet, again, what I said before, the evidence for the use of target elimination diet by standard allergy test is very weak and with very significant heterogeneity among the studies. So it's not recommended anymore. 6-food elimination diet, we know they induce remission in almost 3/4 of the patient of EOE is quite effective. But we have seen the recent studies and all this evaluated during this guideline that less restricted diets eliminating 2 or 4 foods have low response rate, but step-up approach actually may lead to reduced numbers of endoscopies, cost and pendant compliance and quality of life for the patient, and decrease in the number of lost school and work days, which for a kid or whole the family to do 6-food elimination diet, it's quite difficult. This is the dietitians who are important as a partner in this job. As doctors, we don't have the skills or the time to dig on that, and I will show you some slides how deep you have to go with the elimination diet. So in summary of this slide, the ESPGHAN recommends against the use of targeted elimination diet, and we do empirical elimination diet, and we don't use the allergy test anymore. So the commonest allergen from all the studies is cow's milk, egg, and wheat. So all my patients, I tell them to go dairy-free. In UAE and the general Middle East, we are lucky, we have camel milk. I don't have any studies to support that, at least formally, but I have good experience with camel milk, and hopefully we have soon we'll have an ESPGHAN, support a study with that, because it's something which is available in the region, and the camel milk protein has very little homology with the cow's milk protein, so it's something, a potential alternative. And of course, the use of elemental diet that we used to do in the past for very severe cases is still an option, especially for patients with multiple food allergies, true IG allergies, in this case, failure to thrive, or those with severe disease and don't respond to the other treatment. Of course, it has the elemental diet has some backdrops there with you often needs a nasogastric tube to be applied, and the tolerance and quality of life for patients is not good. But if the severe disease or have failure to thrive, all these multiple food allergies is a very good option for the short term. Now, talking about the next part of the armamentarium, we have eosinophilic esophagitis, the topical steroids. We've been using for many years, and it's one of the recommended treatments. What is the best? We still have no clear evidence. We have the classic oral viscous budesonide, which usually mixed with Splenda or honey, or parents use all sorts of things in order to make it thick, a nice, mixture, and usually swallowed at night, or inhaled, swallowed fluticasone. still have no clearance, but in my practice, the oral budesonide is more practical, especially for smaller kids, because the fluticasone needs to be swallowed. It needs good training, and smaller kids I find it quite difficult to have a swallowed inhaler, and usually most of this stays in the mouth, and very little goes to the esophagus in real terms. And of course, when you use topical steroids, you have to make sure you use, make sure you don't have concomitant use of other steroids, such as asthmatic patients who use topical other inhaled steroids, or patients with atopic dermatitis or eczema, where they use topical steroids. So because all these have this cumulative steroid exposure and potential adrenal gland insufficiency. This is how detailed has to be the dietary management and the foods to eliminate. I've asked our dietitians to give leaflets for every food they try to knock out in order to be efficient, and actually they know which foods are contained where. Avoidance of all sorts of potential adjuncts, especially with the milk, which is a lot of things that have milk, especially nowadays, and the knowledge and understanding of product label reading. Every country has different. This is just an example from Canada. And as you can see, all these usual culprits, they have to educate the patient where this could be, and how to avoid. The other thing to consider, and that's why I said the dietitian has to be in you as a partner in this patient journey, is the nutrients which are going away with the milks where you knock out from the elimination diet. As we know, the milk, vitamin D, a lot of protein on the cow's milk, wheat, eggs, soy, peanuts, fish, all the usual culprits. You have all these nutrients which are depleted on the second line, but you have substitutions. So with a good dietitian, you can have a nutritionally complete elimination diet without impact on the nutritional status of the patient. And very important, of course, to meet the nutritional needs. This slide on the side from this publication, you can see all these usual plant milks we use, how much less protein they have in comparison with the cow's milk protein. Especially very popular is oat milk. It has half of the protein of the cow's milk, and almond, which is another one the parents like, it has only 1/8 of the protein of the cow's milk. So all these factors have to be considered when you establish a plan of elimination diet in the patients with esophagitis. So yes, dietary management can be efficacious. The diet therapy can increase risk of malnutrition, though, if you don't have a registered dietitian with you, just to help you with all this we just mentioned. And requires consideration with respect to the food to eliminate, meet the nutritional needs, and of course, the quality of life, the psychosocial aspect of this with the family. So going back to steroid strategies, as I said, we have the classic oral budesonide. This is a dose we use usually in children under 20 kilos, in children less than 10, and adolescents 2 milligrams respectively. Fluticasone, it is effective if the technique is proper, swallowed, and you can have a variable range of the dose. And we have a new kid on the block, which is oral dispersible budesonide. It's called Jorveza. It has come in the adults. I'm trying to get it with some adolescents because it's a tablet which you oral dispersible. You just put it in the tank for 1 minute and then it melts. In Europe, it's already being used by some colleagues, and actually it shows good results so far. And it's much easier than making all this oral budesonide, making sure you have the thick mixture, achieved with the honey or Splenda or any other substitute, usually sugar substitutes. Topical steroids are not without side effects, so have to advise the patient that after taking, you have to wash the mouth, otherwise you get candida. You can get also candida esophagitis apart from stomatitis. You have to also to think about any other extra, as we say, inhalers the patient may take, especially the asthma patients, and think about adrenal suppression. However, this is quite rare, I have to say, but in prolonged use, especially after 3-6 months, is something we have to consider. Do a morning cortisol, and if this is low, you do proper SCPA stimulation testing. I have to say, from the transition clinics I used to do in the UK, the adult colleagues, they use budesonide forever. Because as you can imagine, like it happens with the Crohn's disease, with the diet, adults don't bother, they want to have the social life, they just go and have all of this with budesonide almost for forever. But the kids, when they are growing, we know the risk, we have to be more careful. This is the results of the study published last year of this oral dispensable tablet of budesonide in adults after 48 weeks. And actually the results were quite encouraging and very good. So soon hopefully we'll have some in adolescents at least to start with, and then in smaller children. But the tricky part with that is they have to keep the tablet on the tongue, and it has to melt for 1 minute. Now, another big chapter is the PPIs we use in eosinophilic esophagitis. Again, the biggest difference we have the last 5 years is we don't have the PPI responsive esophageal eosinophilia anymore. We don't have to do the 8-week trial with PPI and then rescope to see if this was true EOE or PPI responsive esophageal eosinophilia. Now PPI has been established as an effective treatment for induction and even maintenance of eosinophilic esophagitis. The way PPIs work is they block the eotaxin-3 production, which is at the pathway of the pathophysiology of eosinophilic esophagitis and the triggering of the degranulation of eosinophils. Now, one small part there, because there are various cytochrome P2C19 pathways polymorphism in the population, it depends on the ethnicity. Omeprazole, lansoprazole, pantoprazole may not metabolize the same way. So I use standard Nexium isomeprazole, which is more available in sachets in pediatrics. So this is less dependent on the cytochrome pathway and less influenced by genetic variability in the gene. So I use that as standard in the management of EOE. Only isomeprazole and meprazole. I haven't seen it available in pediatrics. Now we have PPIs, we have diet, we have the topical steroids. Which one to use? All are possible first-line induction treatments, and all are possible maintenance treatments. So at this point in time, there's no evidence of preference. Every patient is individualized. What I personally do, I put them to definitely dairy. Dairy, if one food you have to eliminate, I see the family, I see the kid. If they're willing, I speak with the dietitians, if they're willing to go the diet, I may go wheat as well, along with egg. But at least if I see difficulty, I say go dairy free. I propose a camel milk because here it's quite available. Some parents don't like it, and they use one of the plant-based milks. But I put a small dose of PPI as well. And if the disease is quite severe, according to the endoscopic score or your experience with the endoscopy, I use also a short course of 3 months, 12 weeks of oral Lifschitz budesonide. So I use sort of combination treatment and try to win. Then after I reassess with endoscopy. How long should the induction phase be? You have a lot of discussion. It's anything between 4 to 12 weeks. Only the actual elemental diet can see results after 4 weeks. Most of the other interventions, you need actually every 12 weeks to have induction treatment. But all the patients, we said this is a chronic disease, we need a maintenance phase. Now the maintenance phase and how to assess and how frequently is a big debate. The consensus was mostly inclined to have an endoscopy at least once a year, or of course, if you have symptomatic relapse, to have an endoscopy again. The problem with eosinophilic esophagitis, as we know, is the reported symptoms that don't correlate with mucosal healing, with histological remission. And of course, there is a balance there. You can't scope the kids every 2 months, or as we see some studies, they're scoping every month, whether introducing food by food, one by one. This is not practical in real life. This is not practical for the health systems, and especially if you work in a private health system, or even the government one. the resources are not there, and I regard it a little bit unethical to put the child every 1-2 months for endoscopy. So after the induction, I think at 3 or 4 or 5 months, at least, probably endoscopy is recommended to have a look and make sure you have achieved histological remission, and then maintenance at least a year, or in case of relapse, you do another endoscopy. Other drugs have been used in the past, like leukotriene receptor antagonist, timatriptan, modelocast, all this. They have been shown that they are not effective. Even worse, some people, they have used thiopurines. This is not recommended by the ESPGHAN, not recommended by anybody in this condition. The new kids on the block are the biologics, which are coming. We have one for the last few years, so omalizumab, use it in adults, but not recommended at the moment for pediatric AOE. But we have more coming, like sendakinumab, dupilumab, which actually is very popular now in asthma, and they show promising results. We just have to wait for the studies to be finished and conducted, and then we'll have some results, so which we will have to watch the space. Now, monitoring evolution, again, we discussed that. The advice is to assess the disease 3 months after the induction, the intervention, even if the patient is asymptomatic. However, this depends on your resources, depends on what system you work. And then once a year, you have to do an endoscopy. Now, this is a standardized pediatric eosinophilic esophagitis symptom score, which is good for research, good for audit, good to have it as a record, but again, it does not correlate with your mucosal healing and histological remission.
Sorry, Dr. Chris. Sorry, we're just short in time, so.
Yes, I will run through the quickly. It's not only 4 slides. Thank you for the reminder. So what is the best? We have the main thing is we want to avoid the strictures. Okay, we don't want the disease to progress from inflammatory phase to fibrotic phase. And then endoscopy has advantages to see the strictures, but also can do barium. We have a imaging study where you can see the length and position of the narrow caliber of the esophagus. So we can use these modalities. We have either balloon, CRE balloon dilatation, Savary, Bucci, or all the same, do the same good job for dilatation. Hopefully, we will not need to do that if we do the treatment where we diagnose the disease early and we do the treatment properly. Systemic steroids can recommend only as a short course in severe esophageal stenosis and severe symptoms, but I would say only for 2-3 months, including the temporary. Now, this is the overall, guidance and algorithm, which soon will be published and they will be available to everybody, like all the ESPGHAN guidelines and position papers. And in summary, what's new for the AOE in 2022, have a new definition. Use of systemic steroids can be considered. We have the risk of anaphylaxis on exposure after food elimination. We have predominantly inflammatory phenotype, endotype type 2 in kids, frequent response to cycle 2 food elimination. No need to do any more the 6 food elimination diet. We can go a step up, unless we have very severe multiple allergies or failure to thrive. We can do amino acid formula. And in kids who have some chance of sustained remission without treatment, or only in PPI, I have a cohort of patients which is like this. And this is something also coming up, the AOE in the eosinophilic GI diseases. There will be an ESPGHAN paper about the beyond the esophagus, and this will come by end of 2022. And by closing, I want to invite all the members, so not only the members, it's open to everybody who wants to contribute, because we will learn more and we will have more data from real world data. So we have a register now in ESPGHAN. It's called Peer Registry, Euro Peer Registry, for more than 10 years now, and it's updated, every 2 years. It's easy, it's free. You just have to put the data there for your patients, and then that's the best. And also, you can be included in publications, and they contribute to the data we need about this disease, which we know only for the last 25 years. Thank you for your time, and I'm sorry if I ran over.
Thank you very much, dear Professor Tzivinikos. That was really awesome, your lecture. I was so excited to have an open discuss session at the end of our gastroenterology session because we had too many questions and comments in the chat section. But unfortunately, we are running out of time, and in about 1 minute later, we had to start the next session. So I have to say sorry that we won't have the open discuss session. Thanks everyone for attending and commenting in the chat section. Thank you very much. Dear Professor Rouhani, if you have any further comments, please help.
Thank you very much. I know we have a short time, but Dr. Chris, thank you very much. Thank you for your nice, great presentation. As I learned a lot from you during many courses of ASPEGAN, and this is another session that I learned a lot. Thank you for very fantastic presentation. As always, it's one fantastic and wonderful. We learned a lot. I'm so very sorry if I want to do something. I like that to stay with you and Dr. Miqdady and the other friends for a long time and discuss a lot of things together. Thank you for your invitation about the registry of eosinophilic esophagitis. It was fantastic. I hope that our colleagues understand and the address, and please send it again to me to give them the chance to register the patients according to your guidelines. Thank you very much. It was fantastic, doctor. I hope to see you.
Thank you very much. My pleasure.
In Tehran very much. Very soon, and I'm very interested. Even Dr. Miqdady is with us. Thank you, Dr. Miqdady, for being with us. Chris, it was fantastic, phenomenal as always. Thank you very much. And I'm sorry that we have a short time for the next session, and we have to say goodbye to all the audience and my best friends and pediatric gastroenterologists of the world, Dr. Christos and Dr. Miqdady. Thank you very much.
Thank you very much.
Thank you.
Hopefully we'll see you soon face to face.
Dr. Miqdady, thank you very much. It was fantastic.
Thank you. Enjoyed.
I hope to see you soon in Tehran.
Thank you. I enjoyed the session very well.
Thank you very much. Thank you very much indeed. Thank you very much. I hope to see you soon. Thank you very much, all of my friends. I hope you are all healthy. Thank you very much. Thank you.
Stay safe. Thank you.